Welcome to this important presentation on the revised treatment protocol for type 2 diabetes mellitus, an evolving health crisis, and the silent epidemic that now touches millions of lives in our state and beyond. In this presentation, we'll walk through a compassionate, updated approach that blends scientific clarity with practical solutions for every doctor, every patient, and every frontline health worker. Background and need for revision. Let's begin with the why. Why was this revision essential? Today, cardiovascular diseases are stealing one in every 3 lives in India. And diabetes? It's silently fueling that fire. Here in West Bengal alone, over 90 lakh people, that's nearly 1 in 5, are affected by type 2 diabetes. This protocol is not just an update, it's a lifeline designed to save hearts, protect lives, and bring consistency across our system. We've included newer medicines, addressed gestational diabetes, and anchored everything in the latest evidence. It's time we treat diabetes not just as a disease, but as a signal to act with empathy, urgency, and precision. Our mission is clear. By 2025, we aim to cut down NCD-related deaths by 25%. Yes, a bold but necessary target. We want better sugar control in half to 3/4 of our patients, and we're striving for treatment that's not only effective, but rational, safe, and affordable. At the heart of this vision lies strengthening our primary care system, because a well-supported PHC is where the first battle against diabetes is fought and won. Diabetes often goes unnoticed until complications appear. We must screen adults age 30 and above, those with BMI more than or equal to 23, pre-diabetes, or a history of gestational diabetes. Also screen if symptoms like excessive thirst, urination, hunger, or weight loss appear. Repeat tests every 3 years, or earlier for high-risk individuals. Reliable testing saves lives. Use random blood sugar, fasting plasma, glucose, postprandial blood sugar, HbA1c if available, OGTT in pregnancy. These tests help prevent complications before they start. Healthy lifestyle is the first medicine. Before any pill, start with lifestyle. Avoid alcohol and tobacco, 150 minutes of exercise a week, reduce cereals, increase vegetables, salt less than 5 grams per day. Avoid reused oil and fried foods. Sleep 7 hours, manage stress. These small changes are powerful acts of prevention. The healthy eating pyramid. Visualize food choices like a pyramid. Base meals on fiber-rich vegetables and whole grains. Add lean proteins and healthy fats in moderation. Limit sweets, red meats, and oils. This model isn't just nutritious, it's life-saving. When is it diabetes? Diagnosis is clear if RBS more than or equals to 200 mg per deciliter with symptoms. If asymptomatic, repeat testing is needed. Act early. Early diagnosis means fewer complications. When to start drug therapy? If lifestyle changes fail after 3 months, or if HbA1c is already more than or equals to 7.5%, start medications. Delaying treatment invites long-term organ damage. Early intervention changes the future. Stepwise drug protocol. Our approach is structured. Step 1. Metformin. Step 2. Intensify metformin. Step 3. Add dapagliflozin or linagliptin. Step 4. Add glimepiride. Step 5. Add pioglitazone or voglibose. Each step balances efficacy, safety, and affordability. Begin with metformin 500 mg once or twice daily. If FPG is between 200 to 250 or PPPG is between 300 to 350, consider dual therapy. Titrate based on GI tolerance. Metformin is effective, affordable, and safe, unless there's renal dysfunction or acute illness. At Step 2, intensify. Metformin. If sugars remain high, increase to 1,000 mg twice daily. Continue lifestyle changes. Review after 1 month and watch for GI side effects. At step 3, add dapagliflozin or linagliptin. Add dapagliflozin 10 mg daily, unless contraindicated. If not tolerated, switch to linagliptin 5 mg. Avoid SGLT2 inhibitors in DKA, UTIs, ESRD. Teneligliptin can be used as an alternative if others aren't available. At step 4, add glimepiride. Start with 1 mg daily and titrate up to 4 mg twice daily. Be alert for hypoglycemia and weight gain after starting this sulfonylurea group of drug. Patient education becomes crucial here. At step 5, add pioglitazone or voglibose. Use pioglitazone 15 mg cautiously in patients with heart failure. Or add voglibose 0.3 mg with meals. Note GI side effects. Choose based on individual needs and tolerance. Glycemic targets. Our sugar goals aren't just numbers, they're shields against complications. Fasting. 80 to 130 mg per deciliter. HbA1c, less than 7%. But goals must be tailored. Elderly or frail patients may need more flexible targets. Aim not just for control, but for a life of safety and stability. When to start insulin? Start insulin. When? HbA1c, more than 10%. Fasting plasma. Glucose is more than 250 or postprandial plasma. Glucose more than 300 mg per dl. Patient is acutely ill, pregnant, or catabolic. Or when 3-drug therapy fails. Insulin is not failure. It's a life-saving tool when used right. Types of insulin. Choose insulin based on the pattern of sugar elevation. Basal insulin for high fasting glucose. 0.1 to 0.2 unit per kilogram per day. Pre-mixed insulin for post-meal. Spikes. 0.4 to 0.5 unit per kilogram per day. Split. 2/3 in the morning and 1/3 with evening meal. Basal bolus for tighter control. Adjust doses every 3 days. Prefer human insulin for affordability. Testing random blood sugar. Follow 4 simple steps. Prepare strip and lancet. Clean the finger, collect and apply blood. Read, record, and safely dispose. This small step forms the foundation of good diabetes care. Cardiovascular risk reduction. Diabetes is a heart disease risk amplifier. High risk. Diabetes alone. Very high risk. Diabetes plus risk factors like hypertension, CKD. Extremely high risk. Diabetes plus known ASCVD. Use statins in all high-risk patients. Add fibrates if triglycerides level more than 500 mg per deciliter. BP target. Less than 130 by 80 in high risk and less than 140 by 90 in others. Antiplatelet therapy. For those at high cardiovascular risk, aspirin, 75 to 150 mg per day for secondary prevention. Clopidogrel, if aspirin is not tolerated. For primary prevention, use only in very high-risk cases. Avoid in low risk due to bleeding risk. Every tablet should be a careful decision. Long-term follow-up. Diabetes is chronic. Monitoring must be continuous. Regularly assess sugars, BP, weight, eyes, kidneys, and feet. This isn't just follow-up, it's how we prevent complications and preserve quality of life. Hypoglycemia. Recognize and treat. Look for cold sweat, tremors, confusion, hunger, palpitations. Treat with 15-gram glucose or a starchy snack. Recheck in 15 mins. IV dextrose if unconscious. Then reassess medications to prevent recurrence. Referral criteria. Refer to higher centers if age less than 25 years, diagnosis is uncertain, severe complications or infections, failure of 3-drug therapy, insulin initiation or morbid obesity. Referral isn't giving up. It's choosing what's best for the patient. Gestational diabetes. Special focus. screen every pregnant woman with a 75-gram OGTT. If 2-hour sugar more than or equals to 140 milligrams per DL, it's GDM. Start with lifestyle changes. If not controlled, use insulin. Metformin may be used after 20 weeks, with caution. Manage sugars to protect both mother and baby. Antenatal care in GDM. Do scans at 18 to 20 weeks and again at 28 to 30. Start low-dose aspirin early in high-risk women. Monitor BP at each visit. Adjust insulin if antenatal steroids are given. This is a critical phase. Guide it wisely. Pregnancy complication. Monitoring. Screen for retinopathy every trimester and postpartum, nephropathy, test creatinine and urine ACR each trimester. Preeclampsia, check BP, urine protein regularly. Rapid insulin drop, suspect fetal-placental insufficiency. Pregnancy care must be rigorous and responsive. Insulin guidelines in pregnancy. Start premixed insulin 30/70, 30 minutes before breakfast. If fasting glucose remains high, add pre-dinner insulin. Adjust every 3 days based on readings. Dose decisions protect 2 lives at once. Referral criteria in GDM. Refer immediately if vomiting and can't eat, FBG more than 200 or PPBG more than 250 despite meds, daily insulin, more than 20 units, frequent hypoglycemia. Act early, don't wait for complications. During labor delivery, induce labor at or after 39 weeks. If fetal weight more than 4 kilograms, plan LSCS. Monitor maternal CBG regularly. Use insulin infusion as needed. Labor is delicate. Monitoring must be continuous and careful. Postpartum management. After delivery, insulin needs drop fast. Adjust therapy. Encourage early breastfeeding. Monitor newborn's sugar every 4 hours until 4 normal readings. Repeat OGTT at 6 weeks postpartum. Discuss future diabetes risk with the mother. This is preventive care for life. Summary key takeaways. Let's bring it all together. Early detection and lifestyle changes form the foundation. Use the stepwise drug protocol for safe, cost-effective care. Screen annually for complications, because prevention is protection. Treat gestational diabetes with urgency and empathy. Refer complex cases early, before the window to act closes. This isn't just a protocol, it's a promise. To our patients, our mothers, our families, let's be the reason someone lives longer, walks stronger, and dreams bigger, despite diabetes. Thank you for walking with us through these revised guidelines. Each slide, each line, was built with one goal: to save lives through better understanding, clearer steps, and more compassionate care. Please share this video with your colleagues, your students, your community. Subscribe for more updates on public health and clinical practice. Together, we can reduce the burden of diabetes, not just with medicine, but with mission. Together, let's improve lives, one patient at a time, one protocol at a time.